Welcome to the DIT 2015 Step 1 Review Primer video on hypersensitivity and complement. This lecture by Dr. McGinnis comes from the 2014 Step 1 Review, and we've chosen this immunology lecture because hypersensitivity disorders are very important for Step 1. We hope you enjoy the video. It's time for the 3-question warm for Immunology 6. Let's get going. What gives rise to the jugular venous A, C, and V waves? So remember, the A wave is atrial contraction, the C wave is ventricular contraction, and the V wave is atrial filling against the closed tricuspid valve. Next question. Which heart murmur is associated with weak pulses? So this is aortic stenosis. Sometimes this is called pulsus parvus et tardus, which is Latin for weak and delayed pulses. Next question. What findings are associated with Ehlers-Danlos syndrome? So depending on the types of collagen that are affected, you can see things like easy bleeding or bruising. You can have hyperextensible skin. You can have joint hypermobility. And because of all this, there might be dislocated joints. That could also be aneurysms like aortic aneurysms or baryaneurysms as well. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about two completely unrelated topics: hypersensitivity reactions and the complement system. So let's start with hypersensitivity. Hypersensitivity is definitely very important for you to know for Step 1. You're definitely going to see some questions on some type of hypersensitivity. Maybe one question, maybe 4 questions. So this is at least a 4-star topic, possibly a 5-star topic. A lot of medical students have a hard time with hypersensitivities, but it's really a pretty basic concept. There are 4 basic types of hypersensitivity reactions. We're going to talk about each type in turn. Type 1 hypersensitivity occurs when some free antigen cross-links IgE that's bound to the surface of pre-sensitized mast cells and basophils. And we talked about this when we talked about the function of IgE. When that surface IgE starts to bind to antigens, it causes the mast cells and basophils to degranulate, to release these preformed granules of vasoactive chemicals like histamine and bradykinin. So these are vasoactive amines. They cause vasodilation and they cause increased vascular permeability, which makes it easier for fluid to leave the vessels and get into the tissue, which means you're going to get some local edema. So this is a wheel and flare reaction, which is commonly called hives. Because these vasoactive amines are preformed, this reaction can occur very, very rapidly. Now, anaphylaxis, like anaphylaxis to a bee sting or to peanuts or other foods, that would be an example of type 1 hypersensitivity. So technically speaking, if you say someone's allergic to medication or allergic to a food, you're talking about an IgE-mediated phenomenon. Now, if they have a food reaction or a medication reaction, it's not IgE-mediated, you shouldn't call it an allergy. You might say they're sensitive to it, but they're not allergic to it. Now, another example would be allergic and atopic disorders like rhinitis and hay fever and eczema. So even though eczema does have a T-cell component to it, it's still considered a type 1 hypersensitivity. And asthma is also considered a type 1 hypersensitivity. Now, to test for type 1 hypersensitivity, if you want to determine if you're allergic to something, you're going to go to an allergist. They're going to do a scratch test on your back. So they prick the skin, usually on the back, and they put these common allergens there. And if you have this type 1 hypersensitivity, you're going to develop a wheel and flare reaction right there where they put the antigen. So the wheel and flare has a very well-defined edge, and it pops up within 15 minutes or so. Type 2 hypersensitivity is where you have antibodies against fixed antigens found on cells. So autoantibodies against cellular antigens would be a kind of type 2 hypersensitivity. And anytime cells and tissues get covered in antibodies, that can activate other components of the immune system. So with type 2 hypersensitivity, you also have complement-mediated damage, or macrophages phagocytose the cells, or NK cells attack those antibody-coated cells. But the main thing to remember is that it started with anti-cell antibodies. Then the test to detect for type 2 hypersensitivity is a Coombs test. Basically, you're using a known marker, like another antibody that binds to those anti-self antibodies, to see if those particular anti-self antibodies are present. And we're going to talk about direct versus indirect Coombs test in the hematology section in a lot of detail, but this is basically a test for autoimmune hemolytic anemia. So let's discuss some specific examples of type 2 hypersensitivity. So we mentioned hemolytic anemia. One example would be an acute hemolytic transfusion reaction where your patient has type A blood and you accidentally transfuse type B red cells. The patient's anti-B antibodies are going to attack the B surface antigens on the donor red cells. Another example would be autoimmune hemolytic anemia, which again we're going to talk about in hematology, but this is where you make autoantibodies that attack your own red cells. There's ITP, or immune thrombocytopenic purpura. It's a similar disease, except here the autoantibodies are attacking the platelets instead of the red cells. There's erythroblastosis fetalis, which is where maternal IgG antibodies cross the placenta and attack fetal red cells. So lots of these are autoimmune disorders, but it doesn't have to be an autoimmune disorder. The only criterion for type 2 hypersensitivity is that you have antibodies that bind to cells. And then one more hematology-related one is pernicious anemia. But here the antibodies don't go after the red cells. Pernicious anemia occurs when there are autoantibodies that attack both the gastric parietal cells that produce intrinsic factor and also antibodies that attack the intrinsic factor itself. Now, without intrinsic factor, you can't absorb vitamin B12 in the terminal ileum. And that B12 deficiency is going to lead to anemia and peripheral neuropathy. When we talked about autoantibodies, we briefly mentioned myasthenia gravis as a situation where you have antibodies directed against your acetylcholine receptors. So that would be considered a type 2 hypersensitivity. We also mentioned Graves' disease, where you have antibodies against TSH receptors. And then in pemphigus vulgaris, you have antibodies against desmosomes or against the protein desmoglein. And bullous pemphigoid is where you have antibodies against the hemidesmosomes. We said Goodpasture syndrome is where you have antibodies against the glomerular basement membrane antibodies. And acute rheumatic fever is a hypersensitivity where antibodies are developed against group A strep, and then they start attacking the host. Now let's talk about type 3. Type 3 hypersensitivity occurs when there are antibodies against soluble antigens in the blood, not antigens on the cells, but free-floating antigens circulating in the blood. The problem here is that these antibodies bind to these soluble antigens and they form antibody-antigen complexes, and those complexes get deposited in the tissues. So it's not antibodies attacking cells that cause the problem, it's antibody-antigen complexes that get into the tissues. And this also incites an immune response, and that leads to activation of complement and recruitment of neutrophils, and ultimately you're going to get a lot of tissue damage. Now, the first example of type 3 hypersensitivity is serum sickness, which is where you produce antibodies to foreign antigens. Now, most drugs aren't proteins, but the drug acts as a hapten, which is a molecule that gets bound to a carrier protein, and then that hapten protein complex can bind to antibodies and form antigen-antibody complexes. So when you hear serum sickness, I want you to think about antibody-mediated drug reactions. But then why is it called serum sickness? Well, basically, in the pre-antibiotic area, they used to treat things like scarlet fever or diphtheria with horse serum, and that contained a bunch of antibodies against these toxins. But after a week or so, some patients would start making antibodies against the antigens in the horse serum, and those antibody-antigen complexes would deposit in the tissues and cause fever and rash and urticaria and joint pain or arthralgias and also proteinuria. So again, nowadays think about drug reactions causing a much milder form of this serum sickness. Now another type of type 3 hypersensitivity reaction would be an Arthus reaction. Now this is a local subacute antibody-mediated reaction where you give an intradermal injection of some antigen like a vaccination, and that injected antigen induces antibodies, and those form complexes in the small vessels of the skin, and that leads to activation of complement and local edema and necrosis. This is usually going to occur 4 to 12 hours after the injection, so this is not as fast as a type 1 hypersensitivity, but it's a lot faster than serum sickness, which takes several days to develop. And then lupus and rheumatoid arthritis and polyarteritis nodosa and post-streptococcal glomerulonephritis are all examples of type 3 hypersensitivities. Then the last type of hypersensitivity is type 4 hypersensitivity, which is T-cell mediated. Now, there may be antibodies involved, but ultimately it's the T-cells getting involved that makes this a type 4 hypersensitivity. T-cells bind the antigen, and then they release cytokines like IL-2 and interferon gamma, and those lead to macrophage activation and tissue damage as a result of that. So the buzzwords I want you to remember with type 4 hypersensitivity are delayed hypersensitivity and cell-mediated. Whenever you hear delayed hypersensitivity, I want you to think about type 4. And remember that cellular immunity takes a while to get ramped up. It's not like type 1 where you have the antibodies lying around ready to go. You've got to present the antigen to the T cells, they've got to make cytokines, and the macrophages have to get recruited, so it's a delayed process with type 4. So think about poison ivy. Poison ivy doesn't start itching immediately, it takes some time. Or think about the PPD skin test for tuberculosis. When do you read a PPD? 48 hours after it was given. So the examples of type 4 hypersensitivity would include the PPD skin test, as we just mentioned, Hashimoto thyroiditis, Guillain-Barré syndrome, multiple sclerosis, graft versus host disease, which is where you have a bone marrow graft and the T cells from the bone marrow end up attacking the host, and contact dermatitis, which includes things like poison ivy or poison oak, some types of latex allergy, and metal allergies like nickel allergy and cobalt allergy. Now, contact dermatitis is definitely high yield, so let's talk about that for just a second. The clue for metal allergy is that you find dermatitis in places where the patient would be exposed to nickel. So you might see dermatitis on the wrist from a watch band, or on the ears from earrings, or on the foot from a buckle on shoes. Or in this photo, there's nickel in the button of this patient's jeans. And right where it's rubbing on the skin, he's getting contact dermatitis. So it's pretty easy to recognize. So again, hypersensitivity reactions aren't too terribly difficult, but you do want to be familiar with them. So let's do a quick whiteboard review to recap. All right, let's group all these different diseases and conditions based on what type of hypersensitivity reaction they represent. So starting with an acute hemolytic transfusion reaction, remember that's a type 2 hypersensitivity. Acute rheumatic fever is also a type 2 hypersensitivity. Arthus reaction was a type 3 hypersensitivity. Asthma was type 1. Remember, all those allergic and atopic diseases are type 1 hypersensitivities. Bee sting allergy, again, allergy, think type 1. Contact dermatitis, remember that takes a while to develop, so that's a type 4, delayed type hypersensitivity. Then eczema, and again, it's an atopic disease, so that's type 1. Graves' disease is antibodies against cells, so that's type 2. Guillain-Barré syndrome is another delayed type, type 4 hypersensitivity. Graft versus host disease is another one, type 4. Hashimoto thyroiditis is also type 4. Then ITP, or immune thrombocytopenic purpura, is type 2. You have antibodies against platelets. MS, or multiple sclerosis, was a type 4 hypersensitivity. Myasthenia gravis was a type 2 hypersensitivity. PAN, or polyarteritis nodosa, was a type 3 hypersensitivity. Peanut allergy, again, any allergy type thing, think about type 1. Post-strep glomerulonephritis, that's going to be a type 3 with those antibody-antigen complexes. Rheumatoid arthritis is another type 3 hypersensitivity. Seasonal allergic rhinitis, or hay fever, is a type of type 1 hypersensitivity. And the last one here, SLE, systemic lupus erythematosus, or lupus, that again is a type 3 hypersensitivity. So I hope you did well on that, and if so, here's your prize. It's going to be a smiley face made out of smiley faces. Next, let's talk about complement. Oh, thank you. That's so kind of you. I think you're one of the best medical students I've ever taught. Complement is basically a group of plasma proteins that work together to complement the actions of the immune system by opsonizing and killing pathogens and clearing them out of the way. Now, you probably look at this complement pathway and think, oh boy, I really don't want to memorize this. The good news is you don't have to memorize it. Let's just focus on a few high yield points instead. First, you need to know the 3 pathways of complement activation and what stimulates each pathway. So there's the classic pathway, which is stimulated by antigen-antibody complexes. So we talked about how type 3 hypersensitivity reactions cause damage by activating complement. So that's the classic pathway. IgG, or IgM, binds to an antigen and then to a C1 complement protein and activates that complement protein. Now, there's also the alternative pathway, which does not require antibodies. Basically, complement can spontaneously activate itself, kind of at a low level all the time. So it can this can either occur spontaneously, or it might be stimulated by molecules on the surface of invading microbes. And then there's also a lectin pathway. A lectin is a protein that can bind to a sugar. So in the lectin pathway, a specific lectin protein called mannose-binding lectin binds to a mannose sugar molecule on the surface of microbes, and that kicks off this complement cascade. So again, definitely you want to know those initial steps for each of the 3 pathways. And then the second thing I want you to know is that C1 is the starting point for the classic pathway. I mentioned that earlier, and I'm mentioning it again now, not just because I like to hear myself talk. C1 is the starting point for the classic pathway. And there's a specific enzyme called C1 inhibitor that inhibits the cleavage of C1 into its active components. And don't get confused, because C1 inhibitor also goes by the name C1 esterase inhibitor. The third big thing I want you to know on the complement pathway is the very last step, which is the formation of the membrane attack complex. So you can think of the membrane attack complex as the end product of activating complement. The membrane attack complex is kind of like a little bomb or a gun or something that has to be assembled on site. It starts with one piece, and you add another piece, and another, and another. And these complement proteins get inserted into the plasma membrane of a cell one at a time. And at the end, once it's all assembled, the assembled membrane attack complex can blow a hole in the plasma membrane of the cell and kill it. So you need to know the specific complement proteins that come together to form the membrane attack complex, which are pretty easy. It's C5b, C6, C7, C8, and C9. Let's also talk about a few of the more testable complement proteins. So C3b is important for opsonization, which is basically a process of coating pathogens so that they're more appealing to phagocytes. It's kind of like dipping the bacteria or whatever in a chocolate fountain. Doesn't matter what the antigen is. When you dip it in that chocolate fountain, the phagocytes are more likely to eat it. So C3b and IgG are the two most important opsonins. C3a and C5a are involved in anaphylaxis. So to be more specific, C3a stimulates mast cells and basophils. Remember, we talked about how mast cells and basophils release histamine, and that causes vasodilation and increased vascular permeability. And that allows fluids to leave vessels and go into the tissues, which means the blood pressure is going to drop, right? And that's why you get anaphylactic shock. And that vascular permeability also leads to edema and swelling of the larynx and the tongue, which is why the throat feels like it's closing up during anaphylaxis. And then C5a is also involved in neutrophil chemotaxis. And then one more time, C5b, C6, C7, C8, and C9 all come together to form the membrane attack complex. Let's also run through a few disorders where the complement system doesn't work the way it's supposed to. So if you're deficient in that C1 esterase inhibitor, that causes hereditary angioedema. Now, we really don't understand how or why this works, but it seems to have something to do with elevated bradykinin. Angioedema in general is bradykinin mediated. So somehow C1 esterase deficiency results in elevated bradykinin. You should also know that these patients should never take ACE inhibitors because ACE inhibitors also increase bradykinin levels, and that can cause angioedema as a side effect. Then deficiency of C3 leads to recurrent pyogenic sinus infections and respiratory tract infections. Specifically, you need to know which bacteria infect the respiratory tract and the sinuses. So we're talking about Strep pneumoniae and Haemophilus influenza that are particularly problematic in patients with deficiency of C3. There's also an increased susceptibility to type 3 hypersensitivity, especially glomerulonephritis. And then deficiency of C5b, C6, C7, C8, or C9, all those are part of the membrane attack complex. So a deficiency of any one of those, you're more likely to have Neisseria bacteremia, both gonococcal Neisseria infections and meningococcal Neisseria infections. And then there's also deficiency of DAF, or CD55 is another name for DAF. DAF is a substance called decay accelerating factor, and it helps keep complement from attacking self cells through that spontaneously activated alternate pathway. Anyway, DAF deficiency leads to red cell lysis and something called paroxysmal nocturnal hemoglobinuria. Let's talk just a little bit about paroxysmal nocturnal hemoglobinuria, or PNH, for just a moment. Now, this is found in your study guide. PNH results from a missing chemical called GPI, or glycosyl phosphatidylinositol, which is what anchors cell surface proteins to the plasma membrane. And GPI is essential to the anchoring of CD55, or the decay accelerating factor, that DAF. So PNH patients can also be missing CD59, which is another surface molecule that prevents the membrane attack complex from destroying cells. So if you don't have DAF or you don't have CD59, you're going to have complement-mediated damage of red blood cells. So if your red blood cells are being attacked and being lysed by complement, that's going to lead to chronic intravascular hemolysis. And then the hemoglobin in the red cells ends up in the urine, and that causes hemosideриnuria. And then another unique finding with PNH is thrombosis, because platelets also get destroyed, and they release their prothrombotic contents. Now, how do you diagnose PNH? There are basically two tests you need to be aware of. Historically, it was with a test called Ham's test. So what's Ham's test? Basically, you're putting the patient's red cells in acid, and if those red cells lyse at a very low pH, that's a positive Ham's test, and that's diagnostic for PNH. The other way you can diagnose PNH is to do flow cytometry. So flow cytometry allows you to look for the presence of certain cell surface markers like CD55 and CD59. So if you do flow cytometry and you don't see CD55, you don't see CD59 on the red cells, that suggests the patient has PNH. Then how do we treat PNH? Well, they may need transfusions because of hemolysis. Because of the risk of thrombosis, we want to treat them with warfarin. And there's a newish drug called eculizumab, which is a monoclonal antibody that inhibits complement and prevents it from attacking the red cells. And it's worth mentioning that eculizumab costs several $100,000 a year, so it's pretty pricey. So that's it for this lecture. Now it's time for the end of session quiz. Go ahead and do that, and then we'll go through the answers. All right, let's get started. First question, which type of hypersensitivity is responsible for each of the following clinical problems? So post-streptococcal glomerulonephritis, we said that's a type 3 hypersensitivity. Asthma is type 1. Rheumatic fever is type 2. TB skin test, or PPD, is type 4. Allergies, anaphylaxis, and hay fever is type 1. Polyarteritis nodosa is type 3. Serum sickness is type 3. ABO blood type incompatibility is type 2. Poison ivy is type 4. Eczema is type 1. Contact dermatitis again is type 4. And Goodpasture syndrome is type 2. Next, a patient suffers from recurrent Neisseria infections. What complement proteins are deficient? Well, this could be any of the membrane attack complex complements, C5b, C6, C7, C8, or C9. And the last question, which complement is responsible for neutrophil chemotaxis? We said that was complement C5a. All right, that's it for this video. I'll see you next time.